I can remember early on in COVID when we weren't allowed to touch the patients and their loved ones weren't allowed to be in the department with them when they passed away. And being the last person that Auntie Flo got to speak to, or the last human touch that she had before she passed on, was a really heavy burden for us as physicians. You know, it was a very, very, very horrible period. So while we might look like we don't care or are too busy, what it looks on the outside is not always what the burden is that we actually carry on the inside.
Welcome to Don't Be Caught Dead, a podcast encouraging open conversations about dying and the death of a loved one. I'm your host, Catherine Ashton, founder of Critical Info, and I'm helping to bring your stories of death back to life. Because while you may not be ready to die, at least you can be prepared. Don't Be Caught Dead acknowledges the lands of the Kulin Nations and recognises their connection to land, sea and community. We pay our respects to their elders, past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander and First Nation peoples around the globe. Welcome, Renee, to the podcast. Thank you for being our guest. Now, in full disclosure, I should mention that we are best friends, and I should also mention that you've just been recently appointed as the medical advisor to Critical Info. So welcome.
Thank you for having me.
Now, what specific aspects of emergency medicine do you find the most fulfilling and rewarding?
Look, I think it's the variety in terms of what comes in the door. I think it's the diversity of the reasons that people present to the emergency department, people from all walks of life, and essentially you're seeing them at their worst. So, you know, sometimes I'll say to people, what were you planning to do today? Because no one ever plans to come and see me. It's not, you know, on the top of their schedule when they wake up on a Saturday morning. So I think for me, it's about helping someone when they're at their lowest, when they're scared, when, you know, they need answers and they want things to be okay, to be able to provide that humanness in a space that's pretty terrifying for a lot of people. You know, helping people navigate that awful time for them, and I suppose also, you know, the part of teaching and guiding and educating my colleagues as well. The part that I really love about my work on a day-to-day basis.
So, Renee, you obviously have a real empathy for your patients that you see, and you obviously certainly have told many stories to me over the time. But tell me, what's probably the most macabre story you've come across when you're, or situation you've come across when you're a doctor in emergency?
Look, I think the first one that pops to mind is not something that relates to my sort of everyday work, but I do sometimes tell this story to some of our junior doctors about spending some time at the Victorian Institute of Forensic Medicine early in my career, and being a person who was in the same space as the autopsies when they were being done. And there was this particular day when I was assisting, and the water police had pulled a body out of the Maribyrnong River. And I was only new to Melbourne at that time, and I didn't even know what the Maribyrnong River was or where it was. But I was part of the autopsy on this body. And I remember speaking to this lovely young lady whose job it was to cut through the sternum and to remove all of the organs from the body for the pathologist to then look for a cause of death. And I remember her telling me that she didn't actually wear any underwear under her scrubs because the smell of the decomposing bodies was so potent that it got into your hair and your skin and your underwear, and it couldn't be washed out. And so if she decided she wanted to wear that underwear on another occasion, it would smell like her workplace. And I thought that was quite an odd topic until I was driving home that same afternoon, and all I could smell in my hair and my skin was the smell of rotting human flesh. And without being very aware of it, I actually was speeding along the road on my way home from work, and I got pulled over by the very same water police. And when asked why I was speeding, and I was only going a couple of Ks over the speed limit, but I was in such haste to get home because I smelt so bad. And the water police I put my window down and they said to me, "Ma'am, do you realise you're speeding?" And I said, "Yes." And I explained that story to them, that I needed to get home to have a shower because I smelt like, what did they call it? They called it decomp. And the very kind policeman obviously was taken aback by the smell of me coming out that car window, and he actually let me go home to my shower without a speeding fine. So it's probably the most creative story that you could ever hear for why someone was speeding.
Yeah, it certainly sounds like it. And why was it the water police that actually pulled you over?
Because I was driving along Beach Road and they were doing something down near the waterfront there, Bay, and it was them who pulled me over.
Oh, that's bizarre. Like, that would never normally happen.
No. What a day at the office.
Oh, that's hilarious. And talking about a day at the office, how is your everyday job affected and influenced your personal perspective on death and end-of-life care?
I think as an emergency physician, while end of life is not something that we deal with every day, it's something that we deal with often. And, I remember pre-COVID, there used to be this principle that no one should ever die in the emergency department. But then we were faced with a global pandemic and the hospitals were just overwhelmed. And sadly now, we don't always have a bed to move that person to where they can die comfortably and with their family around them. So, I think dealing with death on a at least weekly basis, for me, it's commonplace. For me, it's something that will happen to us all. And I think essentially, it's something that can be done well. It's something that the family can know what their role is, can know what their task is, can know what their loved one wanted them to be doing in that space, or it can be done really badly where estranged children come from interstate and decide to have a war with the ones who are at the bedside over what dad would have wanted when dad has just finished telling you what he wants. But the child who's racked with guilt for what they have or haven't done through their life is then faced with, their axe to grind, the burden that they carry, and how it can all turn into a complete disaster in that space. And that's just not what you want.
And that sounds like you've witnessed that happen.
Gosh, yeah. So, when asked how I see a good death and how I see a bad death, for me, it's the cohesiveness of that family group and how they come together to provide those end-of-life wishes for their loved ones, in a time when their own personal circumstances should be put aside and the focus should be on, what would dad have wanted in this space? Or, was dad a religious man, or was dad a Collingwood supporter, or, what is it that he would want right now?
And so that's interesting because there's always talk within the death care industry about, what's a good death? Do we want a good death? What is the definition of a good death? What is a good death to you?
So a good death to me, I think, is one where people have actually talked about it in a time and space when it's not imminently relevant, when you've had that discussion around the dinner table or over a cup of coffee to say, no, I don't want a breathing tube, and no, I don't want someone doing chest compressions on me if I have a heart attack. It's the planned, it's the disgust, it's the, well, I'd like my ashes scattered in the water, or I'd like to be buried under a tree, or, the sort of conversations that are had where we can let our loved ones know what we want, what we would like, and what's meaningful to us. And then the contrast with that is that, there's been no discussion. Even, if I share an example about a patient who had a terminal cancer where palliative care was involved, yet still the discussion hadn't happened. And, I'm having it in the emergency department where the patient is so confused and so close to that end of life where they can't even have a conversation with me anymore. And as the physician, I'm just hoping and praying that I'm not doing something to or for that patient that they wouldn't have wanted, when there's not been a discussion for me to know what's the right way and what's the wrong way. And I go home at the end of my day wondering whether I did the right thing or not. I think that's a massive burden to place on the person who's providing end-of-life care for you or for your loved one. It's a horrible place to be, and it's the days when you go home at the end of the day and just wish that it went another way.
And you're looking at from a medical perspective, but obviously there's emotions involved there.
Of course. Yeah, of course. You may not have met this person before, or, in a small emergency department like I work in from time to time, you might have met that patient 15 times prior. And I always try to have that discussion with patients when they're well. And I will often say to them, I know that this is not relevant now, but let's talk about what you'd like the end of your life to look like, so that we can have some sort of documentation of where the patient wants us to stop or how far they want us to go. And we can talk about their comorbidities and their medical background and what we think as a physician that's appropriate for them or not, at a time when it's not stressful and it's not relevant, so that, we have that documented at a time when it is relevant and when it will actually help us to do the right thing by you, and certainly to make it less stressful for your family.
See, I find that really quite interesting, because I would say that you are a rarity in having those conversations. I've heard about situations where people have gone to their doctor and wanted to have paperwork signed in relation to their advanced care directive and what their intentions are. And, there is some doctors that this particular doctor didn't know the process and was concerned and, about actually signing that. So it's interesting. I think that you would be a rarity in relation to having those conversations and encouraging people to have those conversations, just based on what my personal experience has been.
Yeah, look, I'd encourage everyone to have that chat with your GP. It doesn't matter how old you are. You might step out on the street and get hit by a bus. So just because you're not feeling like you're approaching the chronological end of your life, I think it's a discussion you can have with your GP at any point, and I would encourage you to do so. Next time you're in the emergency department, talk to the physician about that and start to have those discussions, so that your family, when they're at this point, are not carrying that entire burden of never having a discussion with you. And it doesn't have to be a doom and gloom discussion. If you sit around my dinner table at any point of time with my teenage sons, there's a lot of discussion about this sort of stuff. But, I think from what's going on at the football to the last bowel action, anyone who's got teenage boys of any sort,
I can attest to that.
It always turns to poo and farts.
Yeah, I have to agree. Very, very true. Now, just back on the question I asked previously in relation to how your everyday life working as an emergency doctor and dealing with death, how has that affected you personally when you come home? What impact has that had on you?
I think it depends on the type of shift that you have. Anyone who's sat in an emergency department waiting room in the last 10 years will understand how incredibly busy it is. And I think the challenge with that is that when you've got someone who's at the end of their life, or someone who's incredibly sick and you're trying to save that life, we just don't have the time to providing the care that we would like. We don't have the time to sit at the bedside and hold that patient's hand. And, there are times when you come home and that burden is very heavy. I can remember early on in COVID, when we weren't allowed to touch the patients and their loved ones weren't allowed to be in the department with them when they passed away. And, being the last person that Auntie Flo got to speak to, or the last human touch that she had before she passed on, was a really heavy burden for us as physicians. It was a very, very, very horrible period. So, while we might look like we don't care or don't have time or are too busy, what it looks on the outside is not always what the burden is that we actually carry on the inside. Underneath we are humans, and we love and we grieve and we bleed the same as anyone else. And so I think those competing demands of providing care at end of life, but resuscitating the sick person in the resus cubicle who's just come out of a multi-vehicle accident, or the little 3-year-old with the tonsillitis. We care just as much about every one of those patients, but often we can't provide the care that we'd like. And I think that's probably the heaviest burden that I feel like I bear at times.
And I suppose that also it must add an extra layer when throughout your entire career, death is viewed as my perception is that death is viewed as a failure of a doctor.
I think there are certain specialties in medicine where jokes are made about, and all courtesy to all the palliative care physicians out there or the oncologists, but jokes are made about, some physicians still wanting to do CPR on the person who died last week. I think as an emergency physician, we see death often, and we're pretty good at making an assessment fairly early on about what the chances are that we might be able to resuscitate a patient. And certainly, should we resuscitate them? What are their wishes? What are our chances? I think in emergency medicine, we're also very good at knowing what a good death looks like and being equally happy to provide a passing away with a patient where they're not in pain, where they're not in distress, where the family know what to do and know what their role is. I think that's a big part of our job too. So we can do that very well. And I think we're also very making the decision when the time is for that to be our focus. I know at some stage we've talked about how we navigate those conversations, those end of life conversations with patients and families. And, I've kind of alluded to it before about it's so much easier when the family has had a clear conversation. And even when your death is expected or not, the one guarantee of life is death and taxes, don't they say? But it makes it so much easier when the family had the discussion and they know what you want. So, it certainly makes life for me in the emergency a whole lot easier.
And it seems that, you've got a good sense of humour when it comes to dealing with the frenetic pace that obviously you must be involved with every day in an emergency department.
I think as emergency services, police, fireys, the ambos, emergency medicine nurses and doctors, I think we've all got a bit of a dark side. And in fact, I am part of a little group on Facebook where a lot of that dark humour is shared. And clearly it's got to be a closed group because I think some of the ways that we deal with that grief and what we face every day might be a little odd for some people from the outside. But I think as emergency physicians, we're all a little quirky in a way.
And is that also, part of your support network that you have to actually deal with the day-to-day?
Yeah, I think, you generally find that there's you in that resuscitation situation for good or bad, whichever way it's turned out in the end, that team, you bond so tightly as a result of working at those extremes of life and death, the birthing or the passing on of a patient. They're really incredibly emotionally charged times, and your team does bond. There's times when the ambulance services will stay in the resus with us, and you build quite a unit with those people because of the things that you face together and the things that you've worked so hard to try and achieve together, whether you've failed or whether you've actually managed to succeed there. But it really does bring you together, and it enables you to understand each other on a level that I don't think anybody else in the community could even fathom. To be able to come home and share those discussions with my husband or my daughter, certainly there'll be an abridged version of what happened in the office that day. The reality of what really goes on there could only ever be the general public would probably just scratch the surface of what we really go through on any given day.
Talking openly about death and grief can sometimes be triggering. If you find you need support, please reach out to our support services and the bereavement organisations listed on our resource hub. All links are in the show notes of this episode. Thanks for sharing that, Renee, because that is quite personal, the challenges you do go through. Like I know that you share a certain aspect with it with me, but I know that there's a lot that you carry. Has it made you, think about, God, creation, Allah, whatever being that might be? Have you found some sort of faith or spirituality to try and get you through your everyday?
I think some who work in this sort of field have some sort of sense of something bigger than us. And, it's interesting how many people you find who work in emergency services have got some sort of faith beyond themselves. And I think, maybe that's our way of trying to explain the unexplainable, or to try and find meaning in a place where there seems like nothing but chaos. And that can be religion, it can be football, it can be, sometimes the bad stuff like eating and alcohol. But I think we all search for meaning somewhere. And, for me, I do believe that there's something bigger than myself out there. And I think I have to, in order to get up each day and keep going and doing what I do. I think if you believed that only that there was chaos and your role was trying to make sense and order of the chaos, you might find that role a bit burdensome and, essentially not be able to continue each day. So I think you do have to think there's some bigger reason in it than just you and the patient in front of you.
Wow. Yeah, I'm sure. Yeah, it's interesting. It makes me think, to support the role that you do and what you have to deal with on a daily basis, how do you see the role of, services like death doulas, palliative care workers, those people in supporting those families in these situations?
Look, I think that death is done differently by lots of different people. And, we just talked before about different people's, looking for faith or rhyme or reason. Certainly it's something that different cultures do differently. And I think there is absolutely, a broader team that pulls together in these times. And I think we all share a little bit of the part of the process. I can't help but share a funny story, a personal experience actually about a death doula who I tell the story sort of fairly often because I find it hysterical. A friend of the family passed away, and his wife, unexpectedly, he was young with sort of youngish early teenage kids. And it was a death that was expected. He had terminal cancer, and his wife, who was an incredibly educated IT specialist, a bright, fabulous young woman, had engaged the services of a death doula. And to the shock and perhaps horror and dismay of the teenage children, they'd made the decision that was right for her to keep his body after he passed on in the bedroom, on the bed, with a cooling mat underneath for a number of days. I'm not quite sure who decided the number of days that was appropriate for him to remain on that cooling mat. But there was a statement from one of the teenagers about not wanting to go into the bedroom because there was a dead man in there. And essentially, subsequently, the coffin, which was a chipboard box, I believe, that the children had drawn art all over, had subsequently sat on the dining room table for a number of days prior to the funeral, and it was held in the house. And
that was the funeral that was held in the house?
The funeral was held in the house. And then a number of the family members had to remove the coffin from the house down a steep flight of stairs because they lived on a bush block that only had one access sort of up and down a cliff face. And a number of them, including one of the local ambulance officers, had to work together to try and get this very heavy coffin down those stairs. And it wasn't without incident. I won't say any more than that, but let's just say that box did not remain closed for the entire duration of the transport down the cliff face.
Oh, my goodness.
So I kind of think of that for me as being one of the worst or most macabre stories I've heard. Certainly I wasn't there to experience it, but it was the right end-of-life process for the person who organised it all. So while that's completely different to what I would pick for my own loved ones, that was what was right for her. And, in hindsight, it certainly helped her with that grieving process, but I can't help but see the funny side of it.
And the children in the end, you said that they actually decorated the the card, the box.
Yeah.
And
drew some
the coffin
and things that were meaningful all over it. And I think in hindsight, they've actually had a really healthy grief process. I think it, while it seemed all very new and creative to me, I think the turned out really well. So I think we just need to have an open mind that everyone does something differently. And, I can't help but think of I was only pondering about this morning, about that whole concept of a birthing plan. And I'm going to go completely off piste here. But if you know of someone who's, had kids or recently has given birth in the last 10 years, there's this concept of a birthing plan where we go along to antenatal classes and you learn to breathe and you've got your support person there and you write this plan out of all of the things that you do and you don't want. And most of us know that it goes nothing closely to the birthing plan.
Yes.
And you probably end up with all the things that you didn't want. But I just wonder why we don't do that for when we die. We have this thought out plan for when we're going to bring another human into the world, but why don't we have one for when we go out the other side? I actually think it would be really useful.
I totally agree with you. And that was something that I went to a conference last year and it really struck me that I have a son who's now 19 and you're well aware of. And I remember having to go to, classes before he was born and the packs that you got and the information and then the follow-up care with the maternal child health nurse coming out to the home. And I just thought, there is so much thought and planning that has gone into giving birth. But, not everyone gives birth.
Oh.
But we're all going to die. Like you said before, death and taxes, they're the two things that we cannot escape. And yet it's something that has not, well, as far as I can see, hasn't really registered with government organisations that this is something that needs to be paid attention to. And people need to have some sort of support and care and conversations need to be had around it. And hopefully us having this conversation now can start those conversations as well. Mm-hmm. You've touched on a few situations that you've come across when you're dealing with the family in relation to emergency and sort of end of life and those difficult scenarios. Have you ever found that when you're in one of those scenarios and it's very evident that they will not survive and they're going to die, have you ever found that you haven't been able to access information that could have helped with their with their, I can't say recovery because if they're dead, but, or
with the resuscitation process, or look, it happens on a daily basis. Even the person who's come in who's got delirium from an infection, or the person who just doesn't have great health literacy. And while there's that incredibly fabulous My Health record that our government has funded, a lot of people have opted out of that. I just have to encourage you to make sure your GP's uploading the data onto that and to tell you how incredibly important that app is for us to be able to look at and just to even work out your allergies and your medications. It's so useful for us when we're providing frontline care to know your background. I need to share a story as recently as a couple of weeks ago, where I had a patient who thankfully we'd received a bat call. Now, for those of you, it's not about Batman and Robin, but in every emergency department is a bright red phone that essentially looks very much like a 1970s phone with the
I've seen one of those.
The handset and the push buttons. Nonetheless, a bat call came through from the ambulance service who were bringing in a patient who had an unrecordable blood pressure and a heart rate that was very, very, very low. And they gave us their working diagnosis. And essentially, the gentleman had been in our department no longer than a couple of minutes, and we had worked out what his diagnosis was and that this was going to be the end of his life. And in that state, his poor wife, grief and distress, she could barely give us anything about his medical history, his allergies. And it was only after that gentleman had passed away, when I was writing his death certificate, and, I realised I knew nothing about that gentleman. And then I had to start digging for data to work out what actually caused him to end up in this situation. And 4 hours later, after digging through records and finally being able to fill out that death certificate, we realised that man had actually had an untimely death and a preventable death. And I think that situation was the worst, when we then had to bring his wife back and explain to her that his death could have been prevented, and we would need to get in touch with the coroner. And that, that is not the way you want your loved ones to pass away. It's not the way I would choose my own death if I knew that my loved ones would be in that much distress and so distraught. So, you ask me, does it ever happen? I would say it happens incredibly regularly, and it's not just end of life. It's on a daily basis when someone can't provide us their medical history or their information. A number of times when we're working on a John Doe or a Jane Doe in the emergency department, when no one knows who they are or any of their history. So it's incredibly common, and you wonder why you wait so long in the emergency department waiting room. It's because we're trundling around trying to find data in archives and calling GPs and trying to dig up information so that we can ensure that we care for a patient in the most appropriate way.
It's interesting that when you say that the grief of this particular situation you're talking about, it's interesting because I'm sure that person, when they went to their doctor, they probably went to that appointment by themselves. They probably went to repeated appointments by themselves over periods of time, and probably never had a conversation with their partner about what was going on in relation to their health. So perhaps it's the fact that we need to have conversations not only about what our death should look like and what our wishes are for death, but also what's going on in relation to our health on an ongoing basis. Would that be correct in saying?
I think sometimes, doctors, we can be accused of doctor speak. We talk to you in a dialect that often patients don't understand. We talk about health literacy a lot. I work between a city private emergency department, and I work in rural Victoria as well, where health literacy and awareness of what's going on in one's life is so completely different. So I think those discussions are incredibly important to have with the physician and to have with family members. And if you're not sure why you're on a medication, or if you're not sure what something means, then that discussion and to talk about, well, what are the implications of this, and where is this headed?
And I find that sometimes when you go to an appointment at a doctor, like I've actually now, with my chronic pain and the issues that I've had to deal with since a car accident, I actually now write a little list. And then when I have been given, because obviously I see specialists and then I see my normal GP, what I've started doing now is also when I go and get a script made, I make sure that if it's a new script, I check with the pharmacist that it's not going to actually mix or interact with the medications that I'm actually currently on, that he also knows that I'm actually taking. So what other things can you, from your experience, that's just something that I've learnt personally, but what other advice could you give people, I suppose, to, prepare themselves or improve their literacy around their health, medical information, that sort of thing?
I think one of the most useful things that I've seen someone have, and honestly it would have taken them no more than 30 seconds to do, was one particular morning when they were taking their medications, they lined all the boxes up with the labels facing to the front so you could tell the milligrams or micrograms and how many tablets they took, and they took a picture of it on their iPhone. And to be able, in a heartbeat, to be able to have somebody show you that picture and you know exactly what their past history is and their medications. And, all it took was a thought and someone to actually think about what it might be like to be that physician scrambling for data in one of those critical situations. So something like that is so easy. And then the other end of the spectrum is where you get these fabulous people who've got their entire medical history on their phone or somewhere accessible or printed out for you, and they say to you, oh, you can keep that copy. And it is such a delight to have one of those patients who is so across it all. But then the other end of the spectrum, there's various things. I can talk about a man yesterday who, we talk about this term of Dr. Google. He Dr. YouTubed, And
oh dear.
he was a bright man. He told me that his medical knowledge had come from being a long-term investor in biomedical science, and he actually had an incredibly good health literacy, but had actually self-diagnosed from Dr. YouTube. And it was actually sadly right when we did all the formal tests. He had actually accurately diagnosed himself. So, that health literacy, while we laughed about Dr. YouTube because it's not a term I had ever passed my lips before that, but I had said to him, next time, please come sooner. Come and talk to us about this stuff before you, Dr. YouTube. When you've got these symptoms, you need to go and see your doctor. You need to present to the emergency department because early on there might be something that we can do about it.
And you hear recently that with everything that's going on in relation to the change in billing practices with medical centres, it is the concern that people are actually looking at YouTube, they're looking at Dr. Google, they're even looking at TikTok now. Yes, the statistics I heard the other day on how many people now look at TikTok for news and for information in relation to health, etc., is quite astronomical. I can't recall the figures, but how would you suggest, if people are doing it tough, what do you suggest for them to do?
Let's just say I am no dancer, so you will not find me on TikTok. But look, essentially, you can search any number of symptoms on the internet and they'll give you a gazillion different possible diagnoses for those, all of which, may or may not fit your background or your other risk factors. So while Dr. Google exists, and we can't say it doesn't exist, and it certainly presents a bunch of ideas, it makes patients incredibly stressed. And, if you Google the sky is pink, you'll find 10 examples of that. If you Google the sky is green, you'll find an equal number. So whatever you're searching, you'll find that answer if that's what you're looking for. So, I would encourage patients to utilise telehealth. I would encourage patients to utilise virtual emergency departments. There are ways of seeking out that care that don't require a face-to-face consultation anymore. Recently I just needed some scripts updated. Well, I didn't go and take up an hour or half an hour of my GP's time. I essentially booked a telehealth consult, and in 5 minutes we had that all done and dusted. I'd not left the home. In fact, I was sitting at home still in my loungewear. And to me, I thought that was a fabulous utilisation of my own time and her time as well. So, there are changing ways that we can consult with our physicians, and certainly in rural areas, we know that it's a 3-week wait to get in to see the doctor, and as a result, people are turning up to the emergency department so much later than they should be. The appendicitis is now perforated, or the gallbladder is now gangrenous. If you've got pain and if you're unwell, then you need to come to the emergency department, and you'll see a nurse, you'll be triaged, and you'll be triaged accordingly to how unwell you are. And the truth is that, the patients who are not unwell will wait, but the patients who are unwell, we will see. You'll be at the top of the triage category. That's our job, essentially, to keep everybody alive. But I would encourage you to do some research. I would encourage you to write lists. If it's going to be a 3-week wait to get in to see your GP, don't leave it too late. Make an appointment for next month. And then, you'll have a number of things that you'll have remembered you need to talk to your GP by that time. I think we just need to be smart about using those services, and then using your other ancillary services as well. The pharmacists, the community nurses, nurse on call. There are so many other ways that we can get medical advice that doesn't just involve your emergency department and your own GP.
And freeways too. Certainly the nurse on call is fantastic. Yeah. Thank you very much, Renee. So in summary, Renee, what would you say are the key things, as someone who deals with death every day at the coalface of this? What would you say are the things that you would like people to be aware of or act or do?
Well, I think first of all, I've got to say, I don't deal with death every day. I'm not that bad a doctor. What was the question again? Sorry, I got
So
slightly sidetracked.
what would you recommend for people as a takeaway from listening to us speak today?
Look, I think, Catherine, when you first came with the idea that you had about a secure storage system where everything got put in one place, and when I share this story with my colleagues, I say it's got everything from how you want your dog to be cared for to what you'd write on your own eulogy. I think just, talk about this stuff. Find a funny or a comfortable place to talk about this stuff with your loved ones. My family are very clear on how I want the end of my life to look. I've told my husband, don't ever take me to the hospital, which I think is quite a funny perspective. But,
for a doctor, yes.
Yeah, I've shared with my loved ones that I want my body to be donated to medical science. I would like to have the medical students be able to learn human anatomy from the body that I don't need anymore. But I recently have found out about a study that one of the local universities are running where they're looking at the decay process and seeing how long it takes in certain environments for a body to decay. Well, I clearly need to state, while I want my body to go to medical science, I don't want to be left down in the paddock to rot so that I can be recorded for how long it takes my body to decompose.
So you want to be very specific in your instructions.
I want to be in the anatomy lab, and I want the medical students to be learning how to provide care for the next generation from my rusty old parts.
Oh, that's fantastic. Well, Renee, I can't thank you enough for coming and speaking with us today.
Thank you so much for having me, and I'm sorry if my dark and macabre sense of humour has offended a few people or perhaps opened your eyes a little bit to the world of emergency services.
Oh, I think it's good that we can all have conversations and be open. So I think it's good that we're promoting those.
Good on you, and keep doing what you're doing, Catherine. This is a great initiative.
Thank you, Renee.
Bye-bye.
We hope you enjoyed today's episode of Don't Be Caught Dead, brought to you by Critical Info. If you liked the episode, learnt something new, or were touched by a story you heard, we'd love for you to let us know. Send us an email, even tell your friends. Subscribe so you don't miss out on new episodes. If you can spare a few moments, please rate and review us as it helps other people to find the show. Are you dying to know more? Stay up to date with Don't Be Caught Dead by signing up to our newsletter and follow us on social media. Head to don'tbecaught.dead.com for more information and loads of resources.